Hello, everyone. We are going to do this recording over Chapter 36, Inflammatory Heart Conditions and Valvular Diseases. I do want to review shortly before we get into that PowerPoint. In the Documents section of your student portal, there is a cardiac review of Part 2 content is what it's called. And it's essentially a study guide of these last 4 chapters, the heart failure, dysrhythmias, structural and inflammatory abnormalities, which is what this recording is over, and then vascular disorders. So when you open this document, it goes through and kind of highlights all of the important stuff, basically what would have been in the notes section of previous PowerPoints. I put all in one document and added a couple videos in to help you review. So please look over this as you're studying to kind of guide your study sessions. Otherwise, we're going to get straight into this. Chapter 36, Inflammatory and Structural Heart Disorders. Starting off with infective endocarditis. So infective endocarditis is an inflammatory process that affects the endocardium and heart valves, so the inner layer of the heart, including the heart valves or that connective tissue, the mitral, tricuspid, pulmonic, and aortic. The most common cause of infective endocarditis is bacterial, but it may also be fungal or viral in origin. Acute bacterial endocarditis, or ABE, develops over days to weeks. It's a very acute, short onset. But subacute bacterial endocarditis develops over a little bit of a longer time period, over several weeks to months, and this may be associated with pre-existing valve disease instead of as an acute bacterial endocarditis, or ABE. It's usually spontaneous without any other known heart conditions. Again, the most common cause is bacterial, usually staph, strep, or fungi would be the next most common. Organisms will enter the body either through the oral cavity or directly through the bloodstream. The most common is usually directly through the bloodstream via IV drug use or prolonged IV catheters. In the last decade or the last 15 years or so, the most common cause we've seen of endocarditis is IV drug abuse, especially prolonged or chronic heroin users. So oral cavity entrance is usually through conditions like strep throat, infections like mouth or tooth abscesses, dental procedures, and upper respiratory infections. So then the bacteria will go from those locations into the bloodstream and travel to the heart. So what happens here, the patho kind of infective endocarditis, is that vegetative lesions will form on the valves and within the endocardium, the inner layer of the heart, and they consist of fibrin, leukocytes, platelets, and other microbes. So it's an inflammatory process that occurs at those sites, bringing things like fibrin, leukocytes, platelets. That's a good, normal, expected inflammatory response. But having that much concentrated to one area causes that vegetative lesion to form, and that can lead to things like a thrombus or clot formation, which can easily break off of that valve and travel through the bloodstream to cause an issue elsewhere. An incompetent valve, a valve that doesn't work efficiently, dysrhythmias, sepsis, or heart failure. All 5 of those things, thrombus, incompetent valve, dysrhythmia, sepsis, and heart failure, can then lead to death. So these patients can be very, very, very ill and oftentimes require ICU admission. I've seen quite a few patients that come in with infective endocarditis that proceed to go into septic shock, MODS, multiple organ dysfunction syndrome, DIC, disseminated intravascular coagulopathy, So those things are concepts you'll probably learn about in your critical care class. I don't get too caught up in that right now, but those things are really hard to treat. And once you kind of get down that slope, it's hard to get back out of it. It does usually lead to death. The treatment for this, I'm going to skip ahead here, is to treat the sepsis and then typically to perform surgery. So in order to perform surgery, and this is what is such a kicker for a lot of our patients, if they are the IV drug abuse, patients, then it's really hard for them to stop their addiction, and then they have to be like off of the IV drug for a certain period of time in order to have a successful surgery. So since a lot of patients can't successfully do that, it can lead to those bad outcomes. But anyways, risk factors for endocarditis are a previous history of endocarditis, prosthetic heart valves, acquired valve disease, previous heart lesions, rheumatic heart disease, which we're going to talk about in a couple slides, congenital heart disease. You'll learn about that more with like a pediatrics lesson. Pacemaker placement gone wrong. Marfan syndrome is a connective tissue disorder that can put you at risk for having endocarditis or developing endocarditis. Cardiomyopathy, we'll talk about in a little bit. Hospital-acquired bacteremia, IV drug abuse, intravascular devices, and oral procedures. So what are we going to see the patients clinically as? And they're going to come in with an infection. Fever, low grade occurs in 90% of patients. They're going to have very much flu-like symptoms, chills, malaise, generalized weakness, weight loss, and then signs and symptoms of sepsis. So early on, that's things like tachycardia, even a heart rate above 90 is considered high risk. Tachypnea, respiratory rate greater than 20, elevated white blood cell count greater than 11, hypotension, that would be there in septic shock, things like that. If they have a heart murmur, that could be indicative of infective endocarditis. Heart failure symptoms, which again, just refer back to the previous recording about heart failure. And then 30% of patients with infective endocarditis may develop emboli from a thrombus formation that's been released into the circulation, and that can put them at risk for stroke or PE development. What are we going to do here? Again, treat the sepsis. So we get blood cultures before antibiotics in order to identify the type of bacteria and the resistance and susceptibility to antibiotic treatment. Leukocytosis is elevated white blood cell count. We'll usually see that. Elevated ESR is erythrocyte sedimentation rate, and CRP is C-reactive protein. Those are both indicators of inflammation. So they're usually elevated in these conditions. A 2D echo or a transesophageal echo is very important. That's going to get our ultrasound view of the heart structures and function. Treat the symptoms of heart failure. So again, look back at that, treating the fluid volume overload, diuretics, things like that. Antibiotic therapy for sure, if it's a bacterial cause, right, which is our most common cause. Treatment for active infection is usually 4 to 6 weeks of antibiotics, so it's pretty prolonged, and it's going to be of the penicillin type: penicillin, nafcillin, ampicillin, or streptomycin. If they're allergic to penicillin, then there's other options that a pharmacist can help consult and get the patient on the right type of antibiotic. And then the patient's also going to be on prophylactic antibiotic therapy from here on out prior to dental work or other invasive procedures that involve the respiratory or GI tract. So if they've had endocarditis before, or if they have any of these high risk factors, then a physician, a dentist is going to recommend prior to dental work and other invasive procedures that they prophylactically take antibiotics to prevent the development of endocarditis. Nursing management, what are we responsible for doing? Of course, is administer those antibiotics as prescribed, reduce bloodstream infection risk with proper IV site care. So this is why we do what we do when we're taking care of peripheral IVs and central lines. So if we're accessing an IV, we're always cleaning for 10 seconds with that alcohol swab, tubing changed per policy at least every 4 days. So different institutions and facilities have different protocols for that, but usually at least 4 days is recommended. Dressings need to be clean around the IV sites. If they aren't clean, then we need to change them and clean them as sterile as possible. For peripheral lines, for central lines, we do it sterilely. And then monitor for IV site infections. So signs and symptoms of phlebitis, streaking in their arm, redness, pain, warmth to that site. We'd want to pull that line and not use it anymore. The patient is at risk for decreased cardiac output. They are having an infection of the inner layer of their heart and the valve, so it can definitely affect the function of the heart. Activity intolerance, definitely related to decreased function of the heart, and then hyperthermia from the fever associated with the infection. Now we're going to move on to pericarditis. Pericarditis we referred to on the first cardiac lecture in our first chapter. It's inflammation of the pericardial sac, which are those two thin layers that surround the outside of the heart and have fluid within it to help prevent friction as the heart contracts. The pericarditis can be acute or chronic inflammation of the pericardial sac, and it can be dry, which we talked about with the friction rub. You'll hear like a leathery sound if you're auscultating the heart, or exudative, which is like pus fluid buildup around the heart. Causes are viral, bacterial, or autoimmune, and this can, if you remember from the ACS PowerPoint, occur post-MI. So again, increased fluid in the pericardial sac results in, so it can be dry and decreased fluid, or it can be the reverse and be increased fluid. Remember, there's two different things happening. They're both an inflammatory process of that pericardial sac, so they both fall under the umbrella of pericarditis. If there's increased fluid, if it's exudative in the pericardial sac, then that can result in cardiac tamponade, which we're going to talk about in the next slide, and that restricts heart function. So that increase in fluid is really going to cause pressure onto that heart, limiting the amount that the heart can contract properly. Signs and symptoms of pericarditis, we talked about this with the ACS chapter, but chest pain, fever, EKG changes, tachycardia. Your relief is going to be sitting up and taking NSAIDs as treatment. Cardiac tamponade and pericardial effusion is that increased fluid accumulation in the pericardial sac. Your signs and symptoms are anxiety and restlessness. You're going to have an acute drop in cardiac output because all that fluid builds up and it keeps compressing on the heart, and so it doesn't have the room to contract as it should. Chest pain, muffled heart sounds, narrowed pulse pressure, like when we were talking about what a pulse pressure is, that systolic and diastolic number is going to be narrowing, or coming closer together. The systolic will be dropping and the diastolic will be increasing, and that's a result of the decreased atrial filling and the decreased cardiac output. And then JVD, or jugular venous distension, and you can see on the right of this slide in the triangle, this is Beck's triad. You do need to know this. These are the three textbook characteristic symptoms of cardiac tamponade. That's low arterial blood pressure, hypotension, distended and narrowed pulse pressure, distended neck veins, JVD, and muffled heart sounds. If you think about putting your stethoscope over that heart, if all that fluid is surrounding the heart, it's going to be really hard to hear heart sounds. Remember listening to somebody talk in the pool when you were a kid, everything was muffled. So going through that fluid is going to cause muffled heart sounds. Treatment, again, for pericarditis, we're going to get the EKG and echo, relieve the pain with NSAIDs, determine the cause. It's going to be the best way to eliminate the symptoms. Patient education about medication management, compliance with antibiotics. Again, nobody needs to decrease or stop their antibiotics because that promotes antibiotic resistance. Head of bed elevated because their pain is relieved when sitting up and forward. And then if they end up having a complication like a cardiac tamponade, they need the fluid to be removed from that pericardial sac. So what they're going to do is either a pericardiocentesis, that's done in truly emergent situations because it can be kind of a dangerous procedure, and then something called a pericardial window. A pericardiocentesis is where a physician goes subxiphoid, as it shows in this picture, below the sternum, and inserts a very long needle with a 20-30 cc syringe, inserts that while the patient's laying down. They'll kind of angle that towards the heart to the left, and they usually use an ultrasound to kind of guide where their needle's going. They want to enter the pericardial sac and then aspirate that excess fluid out to relieve that pressure on the heart. So they are, again, going at that angle subxiphoid and towards the left shoulder to try to get to the heart. You can see why this would be very dangerous. It's a very big needle, and that could penetrate the heart, which would absolutely be not what we wanted to. This would truly just be if the patient was crumping, like absolutely crashing, about to code because of this. Otherwise, we want to safely get them to the operating room and do a very sterile, controlled pericardial window. So they'll actually open the chest up and visualize the heart to be able to put that needle in and relieve the fluid. Now we're going to move on to rheumatic fever. This is an inflammatory disease characterized by a delayed response to group A beta hemolytic strep. So what's happened here is strep throat has gone unnoticed and untreated, and it's led to a rheumatic fever presentation. All three layers of the heart may be involved. It can also affect skin, joints, and the central nervous system. So this can be very wide affecting and widespread. Prevention is the best treatment, obviously. If we know and educate on how to accurately diagnose and treat strep throat, then it won't ever progress to rheumatic fever because the cause is from strep throat. But if patients don't know that they have strep throat, it goes ignored, they don't get treatment, they don't take their antibiotics, then that bacteria doesn't just go away on its own like we know that a virus would. Bacteria has to have that antibiotic to fight back. So it will just progress. So what's happening with rheumatic fever is that the body has an autoimmune response to the bacterial infection that occurred with the strep throat. And then when that travels through the blood to the heart valves may develop that vegetation like we talked about with endocarditis, lose their elasticity, attract platelets and fibrin, which scar and shorten the valve, very similar again to pathophysiology of endocarditis. And something that's characteristic to rheumatic fever is the development of Aschaf's bodies, which are nodules that are formed from inflammation, which become fibrous and scar the myocardium. So while we can treat patients who have developed rheumatic fever, they can have some long-term effects from the scar development and inflammation process that they experience with this condition. Signs and symptoms are going to be your signs and symptoms of carditis or pericarditis, that murmur, cardiac enlargement, pericarditis symptoms. They can have arthritis symptoms, so inflammation that's affecting the synovial membranes or the joint spaces. They'll have swelling, pain, and tenderness in their joints. The central nervous system develops something called Sydenham's chorea, which is involuntary movements, weakness, speech, or gait disturbance. Or in chronic rheumatic fever, then those changes to the valvular structure, which we talked about in the previous slide, can cause some long-term insufficiency of the heart and can lead to heart failure. So again, remember, we're really concerned with what it does to the heart in this chapter, but it can also affect the skin, joints, and central nervous system as talked about here. How do we treat it? We're going to treat that strep infection with penicillin antibiotic. Again, if they can't take the penicillin or erythromycin for an allergy or whatever, then we'll consult a pharmacist to get the next best thing. NSAIDs and aspirin to treat the pain and inflammation. Prophylactic antibiotics for 5 to 10 years before invasive procedures. So just like that's what we recommend for endocarditis patients, we're going to do the same thing here for these rheumatic fever patients. They can either opt to get monthly penicillin injections or take PO penicillin. It probably just depends on, what they prefer, as well as how severe their signs and symptoms are. And we also want to maximize their cardiac output if they have symptoms of heart failure. Again, we're going to treat those with antihypertensive medications, diuretics to decrease that afterload and preload. They may need steroids, so just a little bit more of that anti-inflammatory component than what the NSAIDs can provide. So the steroids would help treat the symptoms of carditis, and then lots of rest. They're going to be very fatigued, and they need to just rest and let the antibiotics do their work. Also, they're going to need a lot of education on making sure that they get treated with antibiotics if they ever have a strep throat again. So again, what are we going to see? That decreased cardiac output and heart function related to valve dysfunction, activity intolerance. We need to promote bed rest and alternate rest and activity until they get their energy back. They have risk for ineffective therapeutic regimen management. So they are at risk for not being compliant because again, they already didn't see or notice the strep throat. So those things might be connected. So we need to educate on compliance with antibiotics, teach them about good oral care and switching to a new toothbrush if they do develop strep throat. Again, for 5 to 10 years, they need that prophylactic antibiotics before dental work. Avoid people with upper respiratory infections or known strep throat so that they don't get exposure or develop it and don't have to go through all of this again. And then again, early notification of signs of strep throat. Valvular disorders. A couple different things we're going to talk about here. Stenosis and prolapse are the two most prominent valve issues that we see. Stenosis, as it sounds, is that narrowing of the inlet valves, narrow and hardened, so it impedes flow into the next chamber. And then the signs and symptoms we see associated with both of these conditions is based on knowing the heart flow, the blood flow of the heart. So remember that, keep that memorized. And then a prolapse is where the valve doesn't close normally. So just like it sounds to you, different organs can prolapse, like a hernia can prolapse. It's where a portion of the valve leaflets are bulging forward or backwards into a place that they don't belong. And that can lead to regurgitation of blood from one chamber to another, which would not be good, and potential clot formation because there can be some stagnant blood there. And we know what the complications of that are. Problems, this developed from a problem with the chordae tendineae, which are the connective tissues of the valves, papillary muscles, which are the small muscles that open and close the valve, or the valve leaflets themselves could have a problem. So there's multiple different reasons why a valve may develop a prolapse issue. And here's what we'll see. Here, these white strands are the chordae tendineae. These muscles connected to them are the papillary muscles, and they work together to pull open and close those valves, S1 and S2. Those are what you're auscultating when you listen to the heart. This is what a nice, good, healthy valve looks like. All three of those leaflets close together. This is obviously the tricuspid valve. And then a healthy valve, what it looks like when it's open, nice and patent, plenty of room for the blood to flow in and not flow backwards because it's going to close successfully together. In a diseased aortic valve, closed, it may not completely come together. And this would be a good example of like a stenotic valve. It's not opening all the way. Those valves have become inflamed, hardened, scarred. So now they're stenotic and they're not opening wide enough for good blood flow through them. And then this would be what a prolapse valve looks like. If this was an atria and this is the ventricle, then one of the leaflets is flowing backwards or forwards where it shouldn't. And you can see that there's that space there that blood can flow and regurgitate back up into the previous chamber, which would not be good. That leads to that blood clot formation and complications. Causes and risk factors for valve issues. Any valve can be affected, but the most common is the aortic and mitral. Those are your left side valves just because they are the higher pressure chambers of the heart and they work the hardest. And then causes can be rheumatic fever, endocarditis, but from the vegetative lesions that develop because of the inflammatory process, myocardial infarction, autoimmune disorders like lupus, and other connective tissue diseases like Marfan syndrome, cardiomyopathy, and IV drug abuse. Signs and symptoms are going to be completely dependent on which valve is involved. So this is where that blood flow comes in. If blood is regurgitating back, then you need to follow the blood flow of the heart to figure out where it would back up to. So signs and symptoms we may see are murmurs because we're going to have definitely some issues with the flow through the valve. So this is a very common cause of auscultating a murmur. Shortness of breath on exertion, especially if the left side of the heart is affected. Those, the aortic and mitral valves are affected because that regurgitation of blood can go back into the lungs. Palpitations, chest pain, irregular heart rhythms, atrial fibrillation is extremely common, hemoptysis or coughing up blood, syncope or orthopnea, pulmonary edema, heart failure, and fatigue. What are we going to do for these patients? We're going to get a good diagnostic picture of what's going on and what exactly is affected within the valve. So EKG for dysrhythmias, echocardiogram, or a TEE to check that ultrasound structure and function of the heart. Or they may even need a cardiac cath to go in, insert that dye, and see where issues are lying. Treatment, again, depends on the valve that's involved. We want to optimize cardiac output and prevent heart failure. Treat dysrhythmias, prevent emboli formation, putting them onto an anticoagulant medication, and then antibiotic prophylaxis, before dental or surgical procedures, just like your rheumatic fever and endocarditis patients. The ultimate management for these patients is surgery. So we can do a balloon valvuloplasty where we go in, again, we use a balloon and we go into the valve and fix it. So it's exactly as it sounds here. Used for stenotic valve treatment, not prolapse. Please keep that straight. This is to go in the cath lab, blow up that balloon at the site of the valve issue and split those leaflets apart and help open up their patency. So just like you would do against plaque in a vessel within the heart, you do this against the valves and open those up and allow for patency to established. Complication of this is that it could work too well and cause them to be too open and then not close properly back together, and that could cause regurgitation and problems associated with stagnant blood and thrombus formation. But it is a good option for older adults and poor surgical candidates for like an open valve replacement. So if a patient isn't a good candidate for that, they have excess comorbidities and health problems, then this would be a good fix for them. Otherwise, we would just want to take that diseased valve out and replace it. So we can do a couple different options here. The type of treatment depends on the patient's age, their ability to take chronic anticoagulant medications, and their bleeding risk. So we have either a mechanical option or biological options. So mechanical options are ideal for clients that are less than 65 years old. Thrombus is common with these, so they do need anticoagulants. So that's why it's better for those younger folks who are at less risk of falling and developing head bleeds or complications from taking blood thinners. It is a mechanical valve, so when you're auscultating heart sounds, you'll hear that click. And they do last longer, so that's why less than 65, it's ideal to give it to them. They're going to have it for longer and have less complications with it. Biological or tissue replacement, either with porcine or pig tissue, bovine or cow tissue, or human tissue from a cadaver. So this would be like tissue donation after cardiac death or brain death. It is a little bit less durable, and sorry about that, had another internet issue. The biological or tissue valves are a little bit less durable. So for clients that are greater than 65 years old and don't need as long-term use out of it as somebody who is younger, this is ideal for. They don't require anticoagulants, so that's really good. And another reason why, if you suspect the patient is going to be non-compliant with taking anticoagulant medication, then you may push for this option instead. And then you won't hear the click because it's going to be that softer, natural tissue within the body. Nursing management of a patient post-op from a valve replacement procedure is going to be similar to the care that you're going to provide for a patient post-CABG or coronary artery bypass graft. They will have more common concerns with dysrhythmias, and that would be because if you think about what we talked about with the electrical conduction system, those areas hit at valve sites, the SA node, the AV node, the bundle of His, and we're replacing and messing with valves. So it is more common to have conduction and dysrhythmia problems after a valve repair or replacement procedure. They are again going to need those prophylactic antibiotics, anticoagulation therapy. They are going to need to follow up very regularly to get their INR checked, especially if they're on Coumadin or warfarin, because there's a tight range here that we want to keep them within. Therapeutic range is 2.5 to 3.5 for patients on anticoagulant medication. For patients who aren't on anticoagulant medication, normal INR is 1. But again, we want them a little or a little extra thinned in their blood. That's the whole goal. So we do want it to be a little bit higher. And then our last condition here is cardiomyopathy. This is a broad term for any acute or chronic disorder of the myocardium, the muscle layer of the heart, which affects function and structure. There are multiple different causes of cardiomyopathy, and there's actually 3 types of cardiomyopathy. There's dilated, hypertrophic, and restricted. And there's a little bit of difference in symptomology, risk factors, and treatment for each of those things. But what I want you to remember is that overarching, they all may result in heart failure. So just, again, go back through in your head to the heart failure treatment. And that's all I need you to know about this cardiomyopathy stuff. Takotsubo cardiomyopathy is actually broken heart syndrome. So people actually can die of a broken heart related to increased or severe stress, anxiety, or grief. So again, this is an actual condition that can be diagnosed and treated or result in the patient's death. So don't get too caught up in this slide. I'm not going to go into detail on this, but there is dilated, hypertrophic, and restrictive. But you can see how there's different causes and different kind of dysfunction that occurs related to which type the patient has. For all 3 types, well, actually, for all three types, the signs and symptoms of heart failure are common. We are going to kind of work them up all the same. They're going to get an EKG to investigate for any associated arrhythmias or conduction problems. They'll have an elevated BNP, remember, because they do have those heart failure symptoms. Mucus scans or MUGA scans are performed in the cardiopulmonary lab, and they assess how well the muscle is working. So muscle mucus scans. And then the treatment's different based on the type. That's all you need to know. I don't need you to go into the specific treatments for those. That's very specialized. Not something we need to go through in our med surg class, but here's just a good way to visualize what's going on in a normal heart. We have that good normal ventricle structure and function. In dilated cardiomyopathy, you can see that this left ventricle is very like swollen and open and dilated. And then the hypertrophic, at least they sound like what they're called. So they look like what they're called. And hypertrophic overdevelopment of muscle, you can see here, the chamber is actually smaller and can hold less blood because of the thickening of the muscle around that left ventricle. And that is it for our inflammatory conditions of the heart chapter. I will be sending you the rest here shortly. Thank you so much.